So, normal tension glaucoma. It is a variant of primary open angle glaucoma, and there is optic nerve damage, but the IOP is normal, less than 21 millimeter of mercury. So there is optic nerve damage, but the intraocular pressure is normal. It is thought to involve IOP independent factors such as vascular issues. So in normal tension glaucoma, also known as low tension glaucoma, low tension or normal pressure glaucoma, it is a variant of primary open angle glaucoma. The distinction is based on epidemiologically derived range of normal IOP. Depending upon the ethnic background, 30 to 65% of patients with open angle glaucoma, 30 to 65% have an IOP that is within normal range on initial assessment. So in NTG there is IOP less than 21 or equal to 21 on diurnal testing, and there are signs of optic nerve damage in a characteristic glaucomatous pattern. There are visual field loss as the damage progresses, consistent in pattern with nerve appearance, and there is an open anterior chamber angle, and there are no features of secondary glaucoma. There are no features of non-glaucomatous cause for the neuropathy. Pathogenesis, the exact cause remains unclear but may involve vascular dysregulation, structural optic nerve anomalies, autoimmune factors, and low central corneal thickness. So any etiological factor distinct from those in primary open angle glaucoma have not been conclusively determined. Although various mechanisms have been postulated, including anomalies of the local and systemic vascular dysregulation, structural optic nerve anomalies, and autoimmune disease. With the introduction of widespread central corneal thickness assessment, normal tension glaucoma in some patients can be explained by very low central corneal thickness. Overall CCT in patients with NTG is lower than POAG. A small proportion of NTG patients have been found to have marked nocturnal IOP spikes, sometimes only detected on testing in the supine position. Risk factors, the first one is age. Tend to be older than those with POAG, although this may be due to delayed diagnosis. Gender, some studies have found a higher prevalence in females. Race occurs more frequently in people of Japanese origin. Translaminar pressure gradient. This may on average be larger than POAG, which affect the optic nerve perfusion. Ocular perfusion pressure may be relatively lower than in POAG. Myopia is associated with greater likelihood of glaucoma and progression. Thyroid disease may be more common in NTG. Family history. The prevalence of POAG is greater in families of patients with NTG. So the prevalence is greater in families with NTG than in normal population. Mutations in the OPTN gene coding for optineurin have been identified in some patients with NTG, though also in patients with POAG. So another is abnormal vasoregulation. Abnormal vasoregulation. This is abnormal conditions like migraine and Raynaud are more common. So migraine and Raynaud are more common in normal tension glaucoma. Uh, However, other researchers have found abnormalities just as commonly in POAG, migraine and Raynaud. Systemic diseases associated with vascular risk such as diabetes, carotid insufficiency, hypertension, hypercoagulability may also be important. The next is systemic hypotension, including nocturnal blood pressure. Significant nocturnal BP dips may contribute to NTG progression. So blood pressure dips up more than 20%, particularly in those on oral hypotensive medication. The early manifest glaucoma treatment trial confirms that low blood pressure is a risk factor in patients with NTG. The diurnal and magnitude of decrease in nocturnal blood pressure below the daytime mean blood pressure predicts progression in NTG. Obstructive sleep apnea syndrome. So here is a chart which shows nocturnal dip. This is 24-hour blood pressure chart showing a nocturnal dip. So another is obstructive sleep apnea syndrome, may reduce optic nerve perfusion. Autoantibody levels have been found to be higher in some groups of NTG patients by some investigators. Translaminar pressure gradient larger in POAG than in POAG. Ocular perfusion pressure relatively lower than in POAG. Myopia, greater likelihood of glaucoma and its progression. Thyroid disease may be more common. Now the differential diagnosis. So these differentials all should be ruled out. The first one is angle closure. It should always be ruled out by a meticulous dark room gonioscopy. Low CCT leading to underestimation of IOP. It is possible that a thin posterior ocular wall may increase mechanical stress in the region of the lamina cribrosa. So prior refractive surgery and corneal ectasia also lead to falsely low IOP readings. POAG, primary open angle glaucoma, presenting with apparently normal intraocular pressure because of a wide diurnal fluctuation. So plotting a diurnal IOP curve over an 8-hour period, this is known as pacing, during office hours may detect daytime elevation. But detection of nocturnal IOP spikes requires substantial resource commitment. Previous episodes of raised IOP. So it may have occurred as a result of ocular trauma, uveitis, local or systemic steroid therapy. So these are also the causes of glaucomatous changes. Masking by systemic treatment, such as if a patient is on oral beta blocker, so commenced after glaucomatous damage has already been sustained, so oral beta blockers should be ruled out. Spontaneously resolved pigmentary glaucoma. The typical examination features of pigmentary glaucoma tend to become less evident with increasing age. The IOP in some cases of POAG may also spontaneously normalize over time. So it is also the cause. Progressive retinal nerve fiber defects which are not due to glaucoma, such as occur in myopic degeneration, optic disc drusen. Neurological causes, congenital disc anomalies which simulate glaucomatous cupping, such as optic disc pit and coloboma. Neurological causes like optic nerve chiasmal compression, they can produce visual field defects that may be misinterpreted as glaucomatous, and neuroimaging should be performed if there is any suspicion, particularly in young patients. Another cause is previous anterior ischemic optic neuropathy, particularly secondary to temporal arteritis, may give rise to a disc appearance and visual field defect consistent with glaucoma. Non-arthritic AION often occurs in a crowded disc, and the fellow eye should be examined for this. So, previous retinal vascular occlusion should also be considered. Previous acute optic nerve insult, such as hypovolumic septicemic shock, head injury, and miscellaneous optic neuropathies, including inflammatory, infiltrative, drug-induced. So they often be clinically obvious but can occasionally masquerade as normal tension glaucoma. So all these differential diagnoses, they can masquerade as normal tension glaucoma, and they can mimic cupping, and they can simulate as glaucomatous changes. So to rule out these, we should check for these clinical features. First one is history and examination. In history, ask about migraine, Raynaud phenomena, trauma, medication history, episodes of shock, head or eye injury, headache and other neurological symptoms which are related to intracranial lesion. Medications, ask about systemic steroids, ask about beta blockers. The intraocular pressure is usually in the high teens, but may rarely be in the low teens. In asymmetrical disease, the more damaged disc typically correspond to the eye with the higher IOP. So an optic nerve head, the optic nerve head tends to be larger on average in normal tension glaucoma than in POAG, and the pattern of cupping is similar, but acquired optic disc pits, focal nerve fiber layer defects are more common. Peripapillary atrophic changes, they may be more prevalent. Splinter hemorrhages on the disc margin are more frequent than in POAG and are associated with a greater likelihood of progression. These are often missed if the disc is not photographed or is examined without magnification. Pallor disproportionate to cupping should prompt a suspicion of an alternative diagnosis. So always check for pallor. The visual field defects, they are the same as in POAG, although there is some evidence that they tend to be closer to fixation, deeper, steeper, and more localized. In more than half of patients, field changes are non-progressive over a period of 5 years or more without treatment. However, perhaps because of delayed diagnosis, patients tend to present with more advanced damage than in POAG. A high level of suspicion for a deficit pattern suggesting a lesion posterior to the optic nerve is important. Other investigations are as per POAG, although in selected patients the following can be considered. Assessment of systemic vascular risk factors. Blood pressure measurement can be used to calculate ocular perfusion pressure. 24-hourly ambulatory monitoring will exclude nocturnal systemic hypotension in selected patients. Blood tests for other causes of non-glaucomatous optic neuropathy such as vitamin B12, red cell, folate, full blood count, ESR, CRP, treponema serology, including Lyme disease, serum ACE level, plasma protein electrophoresis, and autoantibody screen. Indications for neuroimaging in a patient with normal tension glaucoma, they include loss of vision out of proportion to cupping, loss of color vision on Ishihara testing, visual field loss not consistent with retinal nerve fiber layer dropout, pallor of the neuroretinal rim of the disc, rapid progression despite normal pressure. Carotid duplex imaging should be done. In selected patients, ocular blood flow assessment like laser flowmetry may have useful clinical potential. So, in a patient with glaucoma, undertake neuroimaging if there is deterioration of color vision or if the visual field effect is not consistent with retinal nerve fiber layer loss. Now, the treatment. As a large proportion of untreated patients will not deteriorate, about 50% of patients at 5 to 7 years will not deteriorate. Progression should be demonstrated before commencing treatment in most patients. Progression should be demonstrated before commencing treatment in most patients. Some cases of NTG progress more rapidly than others, and because further lowering of IOP is effective in reducing progression, treatment should be considered in patients with advanced glaucomatous damage, particularly if central vision is threatened and in those with a long life expectancy. Regular assessment including perimetry should be performed at 6-month interval initially. Non-specific advice: patients should be encouraged to take regular exercise. Yoga exercise that involve headstands should be avoided. Medical treatment: prostaglandins are usually prescribed as initial treatment. Brimonidine may have a neuroprotective effect in addition to an IOP lowering effect. So, brimonidine. Topical beta blockers should be used with caution, particularly at bedtime, as they can be systemically absorbed and cause a significant dip in nocturnal blood pressure. Letoxolol is the beta blocker of choice in these circumstances. Another treatment option is laser trabeculoplasty. Particularly SLT is a reasonable option to achieve IOP targets. Surgery should be considered if the progression occurs despite IOP in the low teens. Anti-metabolite enhancement of trabeculectomy is likely to be indicated in order to achieve a satisfactorily low pressure and to prevent IOP spikes. Control of systemic vascular disease such as diabetes, hypertension, hyperlipidemia. In order to optimize optic nerve perfusion, they should be controlled. Systemic calcium channel blockers to address vasospasm have been advocated by some authorities. Antihypotensive measures: if significant nocturnal dips in the BP are detected, it may be necessary to reduce antihypertensive medication. especially if taken at bedtime. Selected patients might be encouraged to increase their salted food intake in consultation with patient cardiovascular physician. Effects of sleeping in a head-up position. The IOP is higher in a flat position than in a 30-degree head-up position. Although this effect differs between individuals, patients with progressive disease should be encouraged to sleep in a head-up position, as the mean IOP is 20% lower in this position than in a flat position in at least a third of individuals. Neuroprotective agents of proven benefit are not yet available. Memantine is used to retard neuronal death in some central nervous system disorder but has not been shown to be beneficial in glaucoma. Ginkgo biloba 40 mg 3 times daily may confer some benefit in selected cases.